Anyway, I'm very grateful that all of you all came out tonight, and obviously what we want to do is we want to make the independent schools feel comfortable with food allergic children. As you know, in the community, many of the public school systems have policies in place and great education, and the private schools sometimes are forgotten, or maybe they don't have the same resources, or maybe they don't have the same critical mass as some of the public school systems do. So, and sometimes even, we don't even have nurses at some of the private schools. Who's going to be responsible for the child with food allergy falls to the school secretary, or maybe the principal of the school. Some of the phone calls that we made to invite the schools to come, I remember one phone call, I got the pastor of the school who said he was the principal and he was in charge of auto-injectable epinephrine, and that he thought he knew how to use it, but this year they didn't have any students with food allergy. So he said, but next time we do, I'm going to call you. And I said, please do. So we try to be a resource in the community, and I mean FASCOT, and probably all of you all have been to our website. Our food allergy support group has now been in existence almost 9 years, and we very much are committed to community education. So I say, very much, if you have an issue or a problem, please let us know. And one of the things that's included in your packet is actually a standing order. So if your school does not have auto-injectable epinephrine, the standing order is blank in terms of you can personalize that for a standing order for auto-injectable epinephrine. And I personally, if you'll contact me, will take care of that order for you, because I think it's that important that you have auto-injectable epinephrine in your schools. Additionally, we have some resources of some pens through Mylan. EpiPens are available for free if you want to enter their program and give them some information. So if your school doesn't have the funds to get auto-injectable epinephrine, there are resources that are available. So reach out to FASCOT, reach out to myself, and we'll try and make that happen. So there are lots and lots of people that put lots of work in tonight, and we'll introduce those people as we go along. But what I'd like to do is start out with a little bit of introduction about food allergy, and hopefully make sure that everybody's on the same page, and then we'll be able to learn a little bit more about how to keep your children safe in your school. So there are lots of people that are listed in your program, and we'll introduce them as we move along. So after we have this discussion, I'd like for you all to be able to answer comfortably, what is a food allergy? Are all food allergies the same? Is a food allergy diagnosis, are food allergies increasing in the country or not? What does a label mean when it says may contain? What are allergic reactions like? How do you recognize them? What do you need to do about them? Are some reactions more dangerous than others? What do you need to do as the primary care provider to that individual that's having an allergic reaction? What's the best treatment? How do you position the patient? When do you call EMS? We're going to walk you through step by step as if it were a fire drill, and you knew exactly what to push, where to pull, and where to go. We're going to make sure that you're that prepared for a food allergy emergency in your school. So what I always like to start out with is a definition. So we need to be very clear, because what the general public thinks is food allergy is not always what we think as healthcare providers. If you were to ask the general population, between 28 and 40% say, oh, I have a food allergy. And what they mean is maybe they eat something and it gives them a little gas, or maybe they eat something and it makes them burp, or maybe something doesn't quite taste right to them. And in their mind, that is a food allergy. We want to be very clear tonight when we talk about food allergy, we're talking about a reproducible immune response that's consistent every time you ingest that particular food. And this particular ingestion can be severe and life-threatening in some individuals. The people that are complaining about cucumbers making them burp really fall in that group of people who have adverse food reactions. And this is a much broader term that means when you eat a particular food, you have some abnormal response that may be uncomfortable, and it doesn't necessarily mean that it's a food allergy. So I'd like to be very clear for the rest of the time when we talk about food allergy, We're talking about a specific immune response that involves specific allergy cells that is, again, reproducible and consistent. So there are lots of adverse food reactions. Probably some of you all know people who have lactose intolerance. That's not really a food allergy. What they lack is an enzyme that helps them break down the milk sugar. There are individuals who say they have problems with wheat or celiac, but that's not actually a food allergy. Again, that's an autoimmune process, and they lack a certain enzyme in their tissue that allows them to break down gluten. So that's not actually a traditional food allergy. And there's also individuals who have gluten intolerance. That's a new category that Dr. Lucy's going to talk a little bit more about. But these are not classic food allergies. Classic other adverse reactions that you are going to see kids have problems with. How many of you have patients, or kids, in your school that have eosinophilic esophagitis? Anybody have those? So if you haven't seen them yet, you're going to get a whole bunch more, unfortunately or fortunately. This is sort of a little bit of a zebra. Patients come in with problems swallowing, and they get difficulty they get a lot of belly pain, they have a lot of GI symptoms, and what happens is that they get their esophagus biopsied. And when they biopsy the esophagus, they find a lot of a particular allergy cell called eosinophils. And those eosinophils, if they're left untreated, will lead to scarring, and those patients will continue to have GI symptoms and difficulty swallowing, and sometimes they can even get food stuck. And what we know in this particular entity is that foods tend to make that allergy cycle worse. And so these individuals will come in with a list of 20 foods sometimes that they have to avoid, but these kids are not at risk traditionally for anaphylaxis. When they eat the food, they continue to have GI symptoms. So this may be a child that comes to your school that tells you they have all these food allergies, but they don't come with an EpiPen or an AUVI-Q. And that's because we don't think they're going to close off their airway or have a classic food allergy reaction. So that's an exception to the traditional kids that you're going to see that need auto-injectable epinephrine. The other group of kids that you're going to see that don't need auto-injectable epinephrine are food pollen allergic kids. These are kids that are going to tell you that whenever they ingest certain fruits or vegetables, their mouth itches, or maybe they have a little bit of lip swelling, or they feel uncomfortable in their oral pharynx area whenever they eat fresh fruit or vegetables. And what we know is that this particular syndrome is due to cross-reactive proteins that are present in pollen and in fruit. And the classic one, for example, that most people know about is ragweed and melon. So there are individuals who are allergic to ragweed, and there's a cross-reactive protein in ragweed that's also found in watermelon. And so whenever they eat watermelon, they complain that their mouth is very itchy and they feel funny, but they never ever get throat swelling, they never ever get hives, they never get any other symptoms at all. And oftentimes these symptoms are worse whenever the pollen is out. If you cook the food, which by the way, cooked watermelon's kind of nasty, then the protein is disintegrated and it's no longer there for them to have a reaction to it. So you may have some kids that come in and tell you, oh, I can't eat apples or I can't eat bananas, and you think, well, gosh, that's a whole lot of fruits. And then you may want to clarify, do you have oral allergy syndrome or oral pollen syndrome? And those kids don't need EpiPens either because their reactions do not progress. And they are actually very common, as many. Does anybody in here have oral allergy syndrome at all? So as many as 40% of pollen allergic individuals can actually have that. So that's fairly common. And then the other entity that I want to, for those of you that may be daycare providers or young infant providers, the food protein-induced enterocolitis syndrome. And these are individuals who eat the food and they actually end up with bloody stools and they can't tolerate the protein for a period of time because of inflammation in their gut. and they usually outgrow this somewhere between 3 and 5. And those individuals, again, are not going to have life-threatening food allergy reactions. They're going to have blood in their stool and GI issues, and most commonly those are milk and soy that cause those reactions. So they're not going to have EpiPens either. So these are going to be the exceptions of children that may come to you with a food allergy diagnosis that are kind of on the different spectrum of food allergies. So now we're going to talk about a traditional food allergy. And in a traditional food allergy, proteins that are contained in foods are actually seen as an invader in the body. And you can see here our mean little mast cell. And on this mast cell, there are allergy molecules that are sitting and waiting to receive their particular allergen that they recognize. And once those allergens are found, then this particular cell in the body gets really angry and releases all of the mediators that it contains in it. And these mediators or chemicals that are released are responsible for the allergic reaction that we see. And the most common mediator, and probably most of you all know, is histamine, and that is the particular substance that sets the cascade of all of the allergic symptoms that we see happen. So normally our body is supposed to ignore milk protein or peanut protein, but unfortunately in food allergy our body confuses it and mounts a response to it. It thinks that it's more of an invader instead of a friendly food. So how common are food allergies? This is very surprising. I don't know how many of you in the room, and you don't have to raise your hand, you're over 50, but I'll raise my hand. But anyway, certainly when I was in school, there was no one in my school at all that had food allergy. And we have seen a significant epidemic that has happened over the last 20 to 30 years where it is very common now to have kids in our schools that have food allergies. In fact, in one of the most recent surveys, 8% of U.S. children have food allergies. That's 1 in 13 school-age children, or actually in the average classroom, that's 2 kids per classroom that have food allergies. And we're talking now about the traditional food allergies, and that's quite a significant number. And of those with food allergies, 30% are allergic to multiple foods, and that's not just peanut. So why are we seeing the increase in food allergy? Well, some people think it's because we're predisposed, and because we have a genetic makeup, there are changes and things in our environment that are now causing us to become more allergic. Some of the popular theories are the hygiene hypothesis. And because we are so much cleaner, because we immunize, because we wash our hands, because we use Lysol on everything we can find, we no longer challenge our immune system with bacteria and viruses. And because of that, our immune system is sort of shifted, and it's got to react to something. So why don't we react to food or react to allergens? And this is a popular theory that it's because we're so clean and well vaccinated that we are seeing more allergies and food allergies in general. Other people say that one of the reasons we saw an increase in food allergy is because we had a shift in what we told new mothers. We said, let's postpone highly allergenic foods until after the age of 3 for the really severe ones like peanut, fish, and shellfish. And some people think that may have been a mistake. By postponing those allergens, we didn't introduce them early into the infant's life when the gut may have been more friendly and may have been more tolerizing to the foods. Other things that have been cited are changes in our pregnancies now. Certainly women are under more stress nutritionally. They don't have as many good vitamins. We're using a lot of antibiotics. Some people feel that because we screen mothers before they deliver their babies and give them antibiotics, that we might wipe out all their good flora before they have the baby, so then the baby's gut isn't colonized with good stuff. And some people think that Tylenol simply during pregnancy may be shifting people's infants towards more allergy. So there are multiple theories and lots of things that people are studying to try to explain why food allergies and allergies in general are increasing. But the bottom line is clearly they are. And multiple theories still don't completely explain why it's happening. So, what are the most common food allergies? So there was a very nice recent study done where they did a study across the United States, and they interviewed 40,000 homes looking to see, do you have a food allergic individual? It was an electronic questionnaire, and they were trying to gather information about the frequency of food allergy across the nation, and also what are the most common foods individuals are allergic to. And in this 40,000 family survey, what you can see here is that peanut actually makes up, of the homes that had food allergic individuals, 25% of them were allergic to peanut, 21% were allergic to milk, 17% to shellfish, tree nut was 13%, egg around 10%, fish, wheat, and soy. So clearly peanut is the overwhelming allergen, but I want to point out to you, we always forget our friend milk, and milk has a very high prevalence too. And I'll challenge you that sometimes milk is harder to avoid in the school environment than actually peanut is, and something we probably ought to think about a little more often. So, and one of the things that also came out of this survey is what is the prevalence of food allergy by age? And what we learned from this is who outgrows what and who does not outgrow. So you can see here initially when we look at peanut allergy, you can see that it's 22% in the kids that are from 0 to 2, and even still here in the kids that are over 14, peanut allergy still makes up a large percentage. So we really don't see peanut allergy outgrown very often. Only about 20% of peanut allergic kids actually outgrow their food allergy. But you can see here where we always thought everyone outgrew milk, actually milk allergy is still prevalent. 18% of allergic individuals are allergic to milk. So it is not something that's as readily outgrown as we thought. So we're dealing with food allergies here even later than we used to think. We used to say, oh, they'll outgrow it by the time they're in school, but they're not. But you can see that fortunately wheat and egg is one that does seem to be outgrown, but not completely outgrown. So what is the prevalence of food allergy by race? This is also from a study by the group that also did the phone survey, and I think it's very interesting because you could see here that the frequency of food allergy is more skewed a little towards Asian and blacks, and white, Hispanic, or other are demonstrated here. And one of the things this study talked about that was interesting is that there are some disparities for access to health care, and that potentially the Asian and black actually may be higher percentages than in what are actually shown here, because they don't always in all the communities have the same access to health care, and so we actually may even see a higher frequency of food allergies in those individuals. So it may be underreported. And also from this survey, I thought it was very interesting. They looked at the geographic distribution of food allergies in the United States, and you can see here, I don't know how many of you follow vitamin D at all, but there's something called the 37th parallel line, which kind of runs across the map right here. And a lot of individuals think that vitamin D is playing a role in our increase in allergies, and that when you have less sun, that you don't have vitamin D available to help with some of the allergic pathways. And it's interesting to see that this is considered to be people that get lots of sun, and this is considered to be people who don't get much sun. And in this particular case, the higher prevalence of food allergy is actually in the people that are getting lots of sun. So some individuals have argued that vitamin D doesn't play any role at all, but the prevalence maps are somewhat confusing. When we look, though, at EpiPen prescriptions, most of the EpiPens are above the 37th parallel, but there's more allergy below. So that makes you think that perhaps people that have allergies are not always getting EpiPens. So there may be some disparity with that also. So And then I wanted to mention for you how much do food allergies cost. And this is out-of-pocket expenses. This is not visits to the ER. This is not visits to the doctor's office. This is what the family has to spend to get auto-injectable epinephrine or buy food for their child that may be special food. The average annual cost per child with food allergy, additional above beyond what the rest of the family's costs are about $4,000 and per child. And the annual cost of food allergies in terms of the total national aspect is about $24 billion of additional resources that are required to accommodate food allergies in this country. So it certainly has a big economic impact in the United States. So let's spend just a moment and move to a more severe allergic reaction, anaphylaxis. Anaphylaxis is a serious allergic reaction that is rapid in onset and may cause death. Most common causes of anaphylaxis are foods, medications, stinging insects, and less common but still potential latex. Anaphylaxis is the leading cause of most of ER visits. It takes about 30,000 ER visits per year. There are 10,000 hospitalizations per year, but fortunately only about 150 to 200 deaths per year. So in the field and also in the emergency room, lots of people are doing a great job, because even though they have a severe allergic reaction, we are not really seeing a very high death rate. And again, peanuts, tree nuts, and shellfish are the leading cause of the severe reaction. And this is from a study of children in Illinois, and you can see here they have tracked over 2008 to 2012 the rate of ER visits and hospitalizations for anaphylaxis. And you can see here on this curve too, even in this short 5-year period, that we're seeing increasing numbers of anaphylactic episodes that go to the ER, and also a small increase in hospitalizations too. So this again supports the fact that we are seeing increasing rates of food allergy reactions also. So it is a big player in the ER, and certainly the emergency room doctors tell me that they, in any given week, will see someone with an allergic reaction that has had to have epinephrine in our area. So these are the key medical facts that I would like for you to focus on and take away for just a moment. The first one is that food allergy is an overreaction of the immune system in response to a food protein. It can affect multiple systems of the body. The second one, even a minuscule amount of food can cause this overreaction or lead to anaphylaxis. The third one, there is no cure yet for food allergies. Strict avoidance is the only way to prevent a potentially life-threatening reaction. An allergic reaction usually occurs within seconds or minutes after ingestion, but can occur up to 2 to 4 hours later. The severity and progression of an allergic reaction is unpredictable, and prompt administration of epinephrine is critical, and a second dose may be necessary. I want to review for you what do you see when someone is having an allergic reaction. And what we like to think about is dividing the body up into 4 different systems: the skin, the GI tract, the respiratory tract, and then the cardiovascular or heart. What we see in the skin is usually rash, welts or hives. Sometimes there can be soft tissue swelling, which we call angioedema. And in very mild cases, we may see a flare in the eczema also. In the GI tract, commonly we'll see nausea or vomiting, and also we'll see a lot of oral symptoms. They may have swelling of their lips, their tongue. Maybe they'll say that the top of the roof of their mouth itches. In the respiratory tract, we see nasal symptoms. Sometimes they'll initially have a clear runny nose. Then they may have sneezing. They can also have hoarseness. You should ask the child to speak to you, and sometimes you can tell immediately that their voice has changed. We also hear cough, We hear shortness of breath, wheezing, and they can also be retracting or sucking in over their ribs if they're having enough respiratory symptoms. And then initially, any child that's having an allergic reaction has an elevated or sped up heart rate. And then as time goes on, if the reaction is left untreated, then they can drop their blood pressure and then become very shocky and faint. And that is a more significant reaction. When we want to know when to use auto-injectable epinephrine, I teach my families that I think two systems, two things happening in separate blocks constitute the need for epinephrine. So in this particular case, if you had a patient that had vomiting and also had welts or hives, then that would be two systems. So that would be enough for me to feel like you need to give auto-injectable epinephrine. And that's how I teach families trying to decide whether or not to give it or give it. Or the other thing that I tell them is that if your gut says, I'm scared or something's really wrong, then we just go ahead and give epinephrine. And what I like to remind my families is that every single month in my practice, I have a parent who comes in and they accidentally stick themselves in the thumb with their auto-injectable epinephrine. Not quite sure how they manage to do that, but every month someone does it. And do you know what happens to those individuals that stick themselves in the thumb? Their thumb is sore. That's it. Well, I take that back. I had one person where the needle did kind of go through their nail, and they did go to the ER for that. But aside from that, nothing bad happens. And so what I tell my families is that if you're waffling or you're not clear or you're scared, then go ahead and give the epinephrine. Nothing bad is going to come from giving the epinephrine. And so I challenge all of you all who are providing care for the kids at your school, if you're a little bit sick to your stomach, if you're like, oh, I don't know, is that 4 hives or 6 hives? Oh, wait a minute, did they just sneeze? Give the epinephrine. No one will fault you at all, and you'll be supported in multiple ways. Now, we'll tell you what you need to do once you give the epinephrine. And that's where Dr. Gibney comes in and tells us a little more about the allergic reaction.